when it comes to acidity, more than 50% of the people are not talking of gastric acid. They are talking of bloating, gas, constipation, not being able to clear their bowels properly. And that is what they say, doc, I am suffering from, they'll use different adjectives, huge acidity.
Hello, friends, and greetings from VLCC, and a very, very good afternoon to you all. I'm Dr. Anju Khai, Vice President and Head Preventive Healthcare at VLCC, your host for the session today. Right? So I'm delighted to welcome and introduce to you our first panelist for today, Dr. Dheeraj Bhatia. Dr. Bhatia has 35 years of clinical consultancy practice in New Delhi and has been a senior consultant cardiologist with Fortis Escorts Heart Institute and Research Center and Max Super Specialty Delhi. And he has been honored twice by DMA and IMA as their Doctor of Excellence awardee.
Good afternoon, Dr. Anju, and good afternoon, everybody who's taken time out again for this continuation of knowledge empowerment webinars, which we hold on the 15th of every month. And it's thanks for the introduction. And I think let's start the ball rolling. We have a very eminent guest speakers.
What is the most common symptom of gastric disease you see in your practice?
Okay, so that's a very important question, because really the most important which we see day in, day out, and I think this is across the board, it may be a cardiologist, neurologist, endocrinologist, most patients, Indians especially, they are obsessed with their bowel movement. So either they will come out with, we have a lot of acidity, or they'll say we have a lot of constipation. These are the two most important things. So constipation, everybody knows, I don't have to define it. But acidity is a very broad term, you know. In our medical way to express it, it means hyperchlorhydria, so which is actually high HCl. So, you know, the stomach makes 2 liters of hydrochloric acid every day. That's a lot. And this has got a function. So to understand acidity, what it really is, you have to know that firstly it is this, and the pH of the stomach is usually from 0.8 to 1.5. That's the normal. So it's really highly acidic. Very, very. So there's a fallout of this, which we'll come to later. But anyway, so acidity, like I said, is a very wide kind of terminology. It encompasses a lot of things. But most people, what they describe is that there's indigestion, by which they mean the food is not going down. वो यहाँ अटका हुआ है. So they feel that. With that, they will say that we'll have heartburn, or they'll say we have bloating, or they will say further on it gets worse, we may have even nausea, loss of appetite, belching. Belching is another very common symptom. So these are the symptoms which they will describe. If you ask me the cause, you know, they say there's a very nice article from Mayo Clinics which said 70%, mind you, of acidity patients, which these symptoms, you'll find no cause. You will search, you will do all your tests, and you will not find any cause. Only 30% you'll find a cause. So then what is it really? But one major thing which stands out for across the board for everybody is stress. So the more the stress, the more the kind of life we guys are leading these days, running, you know, helter-skelter and trying to meet, you know, wherever we've got to get it on time. And, you know, we are finally all landing up as type A personalities, not having time for ourselves and relaxation techniques. So that is one very, very big cause. Very, very, very big cause. Then, of course, there can be many other things like, you know, food substances, reacting to that, allergies kind of things. But I think if you ask me, anxiety is the number one this thing. Here, I just want to pass one small comment. People will across, you know, they'll keep going across to chemists, popping in antacids, which you get over the counter. And very often acidity, because being a cardiologist, I must highlight this in the beginning of a program, that they will keep thinking is this, and actually it may be a cardiac event happening. It may be, you know, angina can present like this, acute myocardial infarction can present like this. So it's okay to treat yourself, but if it gets very agonizing, it gets out of control, then be careful. Be very, very careful. Better to meet a doctor, you know, meet your physician, and if he thinks necessary, then the next level is you meet, you know, a gastroenterologist and work it out. But the acidity is very important to understand. In fact, a lot of people will ask questions that such high acid doesn't harm the stomach. So there's a mucus layer inside, which protects the stomach. We'll get into that more later during discussion time, because I don't want to, carry on, because this is a very large and vast topic. So I'll just kind of summarize the symptoms, cause, and we can go further. Yeah, yeah.
So, doctor, what are the other symptoms because of which one can have acidity and heartburn?
Yeah, so otherwise, it's actually, there are now the other 30%. It all depends, you have to really look into them by getting a detailed history. But very commonly, you will find that a person has got gastroesophageal reflux disease, GRD. So, that is also not really a cause, it's like a symptom coming up. And that's a reflux. Basically, it's a splash of acid going from the stomach to the food pipe, and the food pipe is supposed to be inert to acid. It's alkaline. So if there's something wrong with the valve between the food pipe and the stomach, then there will be regurgitation. Or if one is overeaten, or smoke too much, or bad lifestyle, too much alcohol, that's what they say, when you eat, keep 20-30% of your stomach empty, especially if you're going to sleep right away, because otherwise there's going to be this splash going up and causes a lot of problem. Gallstone is another very, very big thing, which people miss. They keep on taking antacids, and the moment you see that the stones are out, once it's diagnosed properly, then you're through. The acidity just disappears. And H. pylori is another one, not as dangerous as it was first thought. Dr. Thakur will throw exceedingly good light on that. But H. pylori is a bug which lives there and can create a problem. And then, of course, like too much of antacids, they have a reverse problem. Because what they do is they actually cut down the acid in the stomach at certain periods. So then the acid is supposed to kill viruses, go through into the intestines, and they interfere with the normal flora of the intestines. So when that happens, then again, there's a kind of, the whole rhythm goes haywire, and you start having bloating, belching, then the acidity comes up. So these are the common things, which the 30% where you'll be looking at is this. The 70% I would still say is a lot of stress, which all of us are going through, and wrong eating habits. Yes.
Exactly. Interestingly, we have 27 feet of our GI tract, and there are 100 trillion microbes in it, 100 trillion, even more than our body cells that we have. And if we have good bacteria, we are good to go. And if we have bad bacteria, then we are in for trouble. So we'll come to that again. But Dr. Bhatia, fatty liver is also sometimes a very big cause of having acidity. Is it true?
Yeah, so fatty liver is, like, I always say, it's like if not an epidemic, it's like an endemic in this country. You take about 90 people watching this, or 100 people by now watching this webinar. I can tell you about 75 of them would have a fatty liver. And fatty liver really, if you look at it, and one way you can tell is by central obesity. If a person walks in, paunch sticking out, more than 90 centimeters in males, the midriff, abdominal circumference, and more than 80 centimeters in females, you can be sure, there's not only visceral fat, there's a fatty liver. But fatty liver, a lot of people confuse that it's actually coming from fat and cholesterol. It's actually metabolic, which means it's coming from carbs. And the carbs is, again, let me emphasize, high glycemic carbs are very dangerous, which means the ones which don't have fiber. Those carbs which you take, like juices and refined flour, where at once what happens is your sugar shoots up. Those are the most dangerous, because those evoke insulin. So when insulin comes out, insulin is the rakshas in the game. So when insulin comes out, it's known as lipogenic. It converts glycogen into fat, and it also pushes fatty acids and triglycerides more into your into your adipocytes in the abdomen, where the fat is stored. That's why you get that, that kind of thing. So when I talk about insulin, I don't mean diabetes. What I'm talking about, let's be very clear, this is pre-diabetes. And that is why it is so important to diagnose high insulin, or hyperinsulinemia, or what we call, is a consequence of insulin resistance. So anyway, let's not get technical, but basically very important to diagnose high insulinemia or pre-diabetes before diabetes comes, because pre-diabetes is totally curable, while diabetes is only controllable. So again, pre-diabetes in VLCC, we are very proud of picking up so many people with pre-diabetes, those who gain weight very easily and say we're not eating much. We believe them now because we know they've got a high insulin. Those who give us a family history, those who are trying hard and cannot lose weight, those who have fatty liver, those who give you a history of gestational diabetes, but she says now I'm all right, but she's gained weight, her insulin is high, mind you. So that's important. High birth weight babies, unexplained edema, because high insulin causes sodium retention. So that's an MD question. When we teach, we ask them, so, why is it? What is the link between pre-diabetes and hypertension? It is sodium retention, and it causes increased sympathetic flow, insulin. So you'll always have these people with tachycardia, fast heart rate. So many more points, PCOS, sleep apnea. I mean, there's so much into pre-diabetes. I don't want to go there also. But why I brought it all up is this is all one axis, all linked to fatty liver. And who is the devil in this is high insulin.
Right. So one has to take care of refined carbohydrates, sweets and sugars, and, prevent, insulin spikes, and that may lead to, a lot of fat deposition, the visceral fat, and even fatty liver. And that may also bring about certain symptoms of acidity and heartburn, etc. So thank you so much, Dr. Bhatia, for providing very useful insights to our viewers and for laying the foundation for today's discussion. So I am now very pleased to introduce our special guest on the panel, Dr. Colonel S.K. Thakur. Dr. Colonel S.K. Thakur, he completed his MD in medicine from the Armed Forces Medical College, Pune, and he was awarded the Pune University Gold Medal for the year 1984. He then completed his DM in gastroenterology from PGI Chandigarh and has served the Indian Armed Forces for last 24 years, and also was the professor and head of the Department of Gastroenterology at the prestigious Army Hospital Research and Referral at Delhi. And we are so delighted to have you. Welcome to the webinar, Dr. Thakur, and it's such a pleasure to have you with us today. Thank you for joining us.
Thank you very much.
So Dr. Bhatia talked about acidity, heartburn as the main common symptom that most of us, and in fact, all of us have experienced. But if it is long-standing acidity, or we call it chronic acidity, which generally, sometimes, which does not respond to common over-the-counter antacids like Digene or famotidine, ranitidine, or even other medicines like omeprazole or pantoprazole, the common antacids that all of us tend to pop in, So what happens, like, if it doesn't help, even these, if they don't help, what could be the causes, and what tests would you recommend to get a good diagnosis? What is happening actually?
Okay, so I get the question clear, and I think that acidity coming as the first question to me is very appropriate, because most of you will agree that this is the single most important symptom that is discussed in great lengths in the chambers of any gastroenterologist. You are saying that your patient has already received the optimal therapy that is available in the armamentarium of the specialist. He has received antacids, he has received ranitidine, H2 receptor blockers, proton pump inhibitors. So he still sits in front of you and says, Doc, I am not relieved of my acidity. So this is the time when you need to change your direction and look at other causes of acidity over and above acidity or reflux, which you have adequately treated. So one of the most important in this is to have a look at the gallbladder, the pancreas, and the liver. They are very, very composite part of the system, And therefore, a simple ultrasound, I am being specific, upper abdomen. I don't want a whole abdomen. Ultrasound, upper abdomen will look at his gallbladder, his pancreas, and his liver and clarify that there is nothing wrong with what we call the pancreato-biliary system. We've ruled out gallbladder stones by doing this. Here is a time when antacids have been adequately used and the patient is still symptomatic, where I would like to bring in my diagnostic option, the possibility of Helicobacter pylori infection. We'll abbreviate it as H. pylori infection, which I would get an opportunity, hopefully, to discuss in detail later. I like to think whether your patient is suffering from H. pylori, and I'll do appropriate investigation. The third is I like to consider whether this patient's so-called acidity is due to any food allergy, a specific or non-specific food allergy. We'd like to keep it in mind. But before I leave this question or the topic of acidity, I would like to say that we have learned through our experience that the term acidity means differently to different people. What I'm trying to say is, we as physicians are engrossed with acidity as being acid going from the stomach into the food pipe. But the dictum that we have been taught when we postgraduates, and even today we teach, is that when your patient comes in front of you and talks of acidity, just don't pick up your pen and start writing. Please sit back and allow your patient to give his symptoms in detail. And experience has shown that the more you allow your patient to talk, by the time he stops talking, he's already given you the diagnosis. But that requires a lot of patience, which many of us would be in dearth of at the time of a busy private practice. So when it comes to acidity, more than 50% of the people are not talking of gastric acid. They are talking of bloating, gas, constipation, not being able to clear their bowels properly. And that is what they say, doc, I am suffering from, they'll use different adjectives, huge acidity. So the first thing you need to say is, okay, please tell me, what do you mean by acidity? And as he keeps talking, he's gone beyond the stomach. He's talking of the intestines. He's talking of situations in the intestine which could be giving him discomfort. And the most common could be something as simple as, in a layman term, worms, or what we call helminthiasis, giardiasis, and amoebiasis. Very common tropical problem. In fact, one of these studies said that 25% of the population treated. The other thing which could be present is that the person could be having low-grade intestinal infection, what most of our clientele recognizes sebal overgrowth. There could be a low-grade infection which is going on, giving rise to his symptoms. So I would like to say, when I'm facing a patient with acidity, first I'll try to understand what he is trying to tell me of acidity, not what I know and what I can treat. So give him a chance. And then it could be a varied syndrome where you got to pinpoint the cause and treat it and investigate it appropriately.
Right. So just in short, for everyone, what Dr. Thakur just mentioned was that he would like to first check the gallbladder, the liver, and the pancreas, as to see if everything is fine there. Then there is a bacteria, which is going to talk about Helicobacter pylori, which if found in excess may sometimes lead to acidity, and very commonly the parasitic infestation like giardiasis and amoebiasis, which is so common in India. That may be just the reason which needs to be treated. And food allergies are so very common, and also, like you said, small intestinal bacterial overdose. If there is a lot of bacteria, bad bacteria in your intestine, that may lead to acidity. So, Dr. Thakur, giardiasis and amoebiasis that we generally see so very common. How frequently should we get ourselves dewormed? Like, is there some protocol about it?
Yeah, the protocol comes by general guidelines in the place where you practice in a tropical country. When I prescribe many times deworming to my patients, uneducated or a wise patient says, but doc, my stool didn't show any worms. So in India, I think it is futile to do any investigation either for giardiasis or for amoebiasis or for helminthiasis. In educational institutions where there are small children, there is a practice of deworming. They ask us, we give our recommendations depending on the source of water, the food, everything. So in general, we say that once in 6 months to 1 year, we should be deworming the general population. And here it is very important. People try to deworm themselves, take care of their own digestive tract. But I always tell families that the first and the most important person to be dewormed and treated for giardiasis or amoebiasis is or are your food handlers. Please remember, the people who are handling, it is better to deworm a few cooks in a school kitchen rather than deworm all the children. The most important thing is don't focus on yourself, focus on the source of infection. So the average would be about 6 months to 1 year better. But when we get patients who are having frequent symptoms and are not able to be explained, then irrespective of whenever he received his previous dose, we give another dose. This is called empirical treatment.
Wonderful, wonderful. So it's very important to take care that if you have cooks at home and somebody else cooking for you, we have to deworm them also. That's really interesting. Yeah. So, Dr. Thakur, we have been talking about acidity, and we just now talked about the bacteria, Helicobacter pylori, and it seems to be a common bacteria that grows in our digestive tract and attacks the stomach lining. But usually it's found to be harmless. That is what it says. But also, it is also responsible for ulcers in stomach and small intestine. So how do we diagnose correctly, and when do this bacteria, Helicobacter pylori, it becomes serious and causes unpleasant symptoms?
This topic of H. pylori, I like to just go into a little detail and say that unfortunately, a lot of the information that our patients are, the general population acquires about this is from Google and from internet and from the Western experience. And most of them, when they are tested positive or informed that they are H. pylori positive, there is a general setback to the patient that he is suffering. And in my experience, I've had people coming with files from the first opinion, second opinion, and the patient, as he sits down, he says, doctor, I'm suffering from the serious disease of Helicobacter pylori. I have made it a habit in my practice to explain the patient in such a way that when he leaves my chamber, at least I have removed more than 50 to 70% of his apprehension of H. pylori. Because believe me, with H. pylori infection, what harms the patient more is not the bacteria H. pylori, but it is the unwarranted and misinformation that the person is carrying and self-traumatizing himself. True. Now, to justify that it is nothing to be very worried about, the data that I like to say is the first thing is, what is the prevalence of H. pylori? You take a Western study, 10%. You take Indian studies over the board. The prevalence rate of H. pylori in the general population varies from 30 to 80%, average 60%. Oh. In a country with a population of 130 crore, 60%. So does it mean that 60% of your population is suffering from a disease? Not at all. We may harbor the H. pylori infection, but only 20%. Only 20% of the people who are harboring H. pylori get clinical manifestation of disease. And this clinical manifestation of disease could be various things. It could be gastric ulcer, gastritis, malabsorption. It could be iron deficiency, vitamin B12 deficiency, duodenal ulcer. So the most important thing is, when you have suspicion of an H. pylori, either the person himself or he's been informed, or he goes to a senior physician or a gastroenterologist, it is the mandatory duty of the specialist to first confirm the diagnosis from the data that has been brought and then treat it appropriately. Anyone who is asymptomatic with H. pylori infection, there are studies. They say you should not go treating everyone who is tested H. pylori positive. Now, how does one test positive? Since there are non-invasive tests, a stool test, a blood test, and what is called the C14 urea breath test, most of the patients will get their test done. They'll get the report and they come to the physician. The doctor is not diagnosing it, but the patient, when he gave his samples, it was said, okay, we are also doing a test for H. pylori. Should you do it? He says, okay, go ahead and do it. He forgets the purpose for which his blood tests were done, but he comes around with this one report. So these tests are not sensitive enough, because once infection takes place, the antibodies are likely to remain in the body for years. So non-invasive tests have very little role. Now I get a patient in a given clinical situation. He's had a GI bleed, he's got a gastric ulcer, he's got duodenitis. Then the gold standard for diagnosing H. pylori infection is slightly invasive. That is a OPD procedure, upper GI endoscopy. You do a small biopsy, which is painless. The patient doesn't come to know about it. And then either you put it on a slide by the bedside called the rapid urease test, or you send it in an appropriate medium to the lab for a stain called Giemsa stain, and you see the bacteria. In a given clinical situation, symptoms are present, H. pylori present, active infection, treat it. But if your symptoms and the reports are not matching and they were done coincidentally, I don't think the patient should be given 14 days of treatment without due justification.
Wow. Okay, that's really interesting. And so once we have diagnosed this, doctor, suppose we do find H. pylori and the symptoms are matching and we need to treat the person. So how do we treat, and is there any relapse rate? Does it relapse very quickly? And what happens if we don't treat it at all?
Okay, so I'll give very brief three answers under three headings. One is the treatment, eradication rate, and the relapse rate. Yes, the treatment is available over the counter. In India, it is available over the counter. And here a stage comes when we have to not treat our patients, we have to stop our patients from treating themselves. We keep telling them, okay, if you don't improve, for God's sake, don't go and start treating yourself with a 14-day antibiotic plus anti-acid regime. Wait for me to give you the green signal. So there is a triple drug combination. It's called a kit. We give it for 14 days, and the eradication rates, next point, is about 80 to 90%. So once you've taken it in India as a routine, we don't repeat the test to see if he's eradicated or not. We've done it earlier as postgraduates, as a part of our postgraduate thesis, but not in clinical practice. And the third is, once you've eradicated it with good treatment, good compliance. Very important point I'd like to mention is, anyone who genuinely deserves an H. pylori treatment, you give him the kit. It's a kit, 3 pills in the morning, 3 pills in the evening, 6 pills a day into 14 days. More than 60% of the patients will start sending you SMSs, WhatsApp messages that, doc, can I stop it? Because there are 2 antibiotics in that. So very important when you say eradication or relapse is the compliance. So we tell our patients, I'm going to give it to you only if it is mandatory. But if I'm giving it to you, please make sure you take it. The relapse rates are not a problem at all. In different studies, they have said that relapse rate they study after 1 year and 3 years. 1 year maybe 2 to 3%. At 3 years maybe 5 to 6%. So relapse is not a problem. Eradication, good success rate. Treatment readily available. The bottom line is compliance to the therapy as and when prescribed by your treating physician.
Very important. So please leave the treatment to your doctor. Let him or her examine you completely and give you the right treatment, and don't go over the top and get yourself treated yourself. So that was really, really nice, Dr. Thakur. And so let's go forward. And now comes our gallbladder. So which is another area which is so very common. So generally people ask, what is biliary or bile sludge? And can biliary sludge also cause bloating and acidity? And how is it diagnosed? And what happens to it? Does it lead to formation of stones, the gallstones? And we'd like to know more about it from you.
So I think this is a very common clinical problem, biliary sludge, and interestingly, for those people where it's the term is sounding too medical, basically means bile, which is clear, containing a little bit of sediment. So that is biliary sludge. So biliary sludge is something which, interestingly, we don't tell our patients. Our patients come to us saying that they have got biliary sludge because he or she went for an ultrasound for some other purpose. Maybe she went for a gynae reason, maybe she went for whatever reason. And a male patient went for some non-specific symptoms. And the ultrasonologist rightly says that your whole abdomen ultrasound is perfect. You have no problem. You've got sludge in your bile. Please go to your physician. So this is something where I don't tell my patients. My patients come and tell me, okay, doc, how do I, any problems? No problems. Why are you here? I'm here because of this report. Wise, very sensible. So how to approach it? Now here I'd like to clarify that when you look at the gallbladder on ultrasound, and please remember, people are doing CT scans, this thing. No. The one and most important test to pick up the best of the gallbladder information is ultrasound, not CT scan. Many people have said CT scan has been done, gallbladder was normal. I said, sorry, go get an ultrasound done. So when an ultrasound is done for the gallbladder, you'll get three situations. One, the gallbladder is nice and clean and full of healthy bile. That is called A calculus. A means without stones. The other extreme is gallbladder stones. They've already formed. So that is called multiple gallbladder stones. Now there is a transition phase in between, biliary sludge, where the thick bile, the sand collects, and this, if allowed to progress, will develop into stones. So there has to be a transition between clear bile and stones, and that is called biliary sludge. Now, when a person comes to me with biliary sludge, please remember that we just don't go treating it without understanding why does he or she have biliary sludge. In other words, is this biliary sludge the cause of my patient's symptoms? Or does my patient have some symptoms because of which biliary sludge is forming? For example, a patient who is on a prolonged starvation diet. He's lost weight, let's say medically or otherwise. We find people, in fact, you have more experience on that there are people who will follow regimes of unjustified weight loss. Hours and hours they are not eating because they have a crash diet, which no one recommends. So where the gallbladder is not being allowed to contract, there's no pressure on it, there's no food, he'll form sludge. So the sludge could form either because of the patient's illness, activity, lifestyle, or sludge could be the transition phase heading for a gallbladder stone. So basically very easily treatable. Once it's been recognized, there are tablets available, medicines available, which will contract the gallbladder, make the bile more liquid, and flush out the gallbladder at the sludge level, rather than coming years later with well-formed stones for which there is only one treatment, and that is gallbladder surgery.
Right, right. Interesting, very, very interesting. So, yes, so that was interesting. So, biliary sludge, it's just like a paste or a sandy fluid, and it needs to be taken care, and so that we prevent the formation of biliary or the gallstones. Coming back to the liver now, Dr. Bhartia already talked about fatty liver. And that's become so very common with everybody, everybody who comes to us and even amongst ourselves. So we would like to know more about it. And what is this fibroscan liver? And should it be done for all the cases of fatty liver? And so we would like to know more about this, Dr. Thakur.
In fact, we have been asked many times, my patients ask me, they say, doctor, the ones who've crossed middle age, that we've lived a very good life, we never had a problem. Why is it that so much of focus, so much of data, so much of literature, so much of media coverage on fatty liver? Why is it? We've never had this problem earlier. Why are we talking of fatty liver now? What has changed? So we need to explain them. What we need to explain them is that earlier we were ignorant. We did not know. We did not know. They say the eyes do not see what the mind does not know. So we didn't know that something like a fatty liver existed. We got patients with cirrhosis liver. When we were undergraduates and postgraduates, we were told there are 3 causes or 4 causes of cirrhosis liver: alcohol, hepatitis B, C. And when you can't find a cause, cryptogenic. Cryptogenic means cause not known. 25 years back, we accepted it. Today, all that cryptogenic is fatty liver, which has been developing over the last 20, 30 years. We didn't know about it. Today, we know more because our information, our knowledge, and we've got the facility to detect fibroscan. Through a fibroscan to detect fatty liver. So what is fatty liver basically? And here, as it was introduced by my previous speaker, we are not touching alcohol. That's a completely different topic. We are talking of fatty liver, non-alcohol group. So that is abbreviated as, and even most of our patients use the term NAFLD, non-alcoholic fatty liver disease. I get an elderly obese lady coming in my clinic with swelling in the feet, and we diagnose her as liver cirrhosis. So when you tell her, she looks at you and she says, "Doctor, what are you talking? I've never touched alcohol and you're trying to tell me I have got liver cirrhosis." So the effect of fat on the liver over the long term is almost equal to that of alcohol on the liver. So this is called non-alcoholic fatty liver disease. Who are the 3 groups of people at risk? Who are the 3 people? And for those of us who are hearing this, please remember, this is not to scare you. We are only here to educate you. It is better to be woken up today about something which is likely to develop in any of our kith, kin, near and dear ones 20, 30 years later. One, those of us who have diabetes. Till recently, the diabetologist only focused on diabetes, blood sugar, insulin, HbA1c, good job done. Today, diabetologists are referring patients of diabetes to us. This patient seems to have fatty liver, please manage. So, diabetes. Second is those of us who have got high blood cholesterol and triglycerides. It was mentioned earlier, fat depositing around the waist. This is called trunk. This is the part of the body called the trunk. It is called truncal obesity. Those who have got truncal obesity, those who have got high cholesterol and triglycerides, and those who have got diabetes. The 3 at risk individuals. And you'll be surprised today. In fact, almost every other day, which includes today morning, I was smiling when I was examining a young boy of 17 years. Wow. 5 feet 9 inches, weight 104 kg, and we are sitting discussing fatty liver at 17 years age. Now, the issue of fatty liver is it is asymptomatic, and that's the problem. You tell a patient who is asymptomatic, whom you have picked up as fatty liver, and then you will give him some restrictions. Don't do this, don't do this, don't do this. You please take my medicines. He is a sincere patient. He walks out of my chamber. He looks back and he says, "Doctor, I will do everything that you have said. But please tell me, what is the purpose of doing all this? I have no symptoms. I have no problem. And you've written, don't do this, lose weight, don't take carbohydrates and some medicines. मेरे को तो कोई तकलीफ ही नहीं है. Why should I take this?" Then we need to explain that we explain our patients that everything in medicine is not curative. There is something called preventive treatment. If you are not going to, why does one go for a tread? If you've got a cardiologist here, a treadmill. Why does one go for a stress echo? You pick up coronary artery, which is being picked up on a stress echo. What do? You wait till he gets a heart attack. Sorry, you're going to stent it tomorrow morning. So that is what I explain him. At the age of 17, if this is the situation, imagine 20 years later, you will still be a very young man of 37. And what will happen to your liver? So that is why NAFLD is also called a pandemic of the future. In fact, we had a big seminar some time back in which we spoke, and the title was Fatty Liver Disease, a Pandemic of the Future. So I'm going to prevent this for your future good health. And you shouldn't turn around and say you came to me and I said what everyone else says in general public. फैटी लिवर तो सबको होता है भाई, फैटी लिवर तो सबको होता है, बट इनमें से बहुत many people will land into permanent irreversible liver damage. Early detection and treatment.
Very, very nice. So, Dr. Thakur, what would be the specific treatment for fatty liver? And you talked about various lifestyle changes. So, would you please elaborate about this?
Yeah, you see, when you are here, it's like that advice to every patient. And I've learned through experience, and you will agree with me, advice on, let's say, fatty liver, 3 different patients. Advice will be completely different in all 3. Reason: an 80-year-old gentleman comes to me, he is having his 30 ml into 2 per day, and he says he's got fatty liver. I think he's looking fitter than what any of us would look at that age. He says, "Doc, I've got fatty liver. What do I do?" I said, "You file this in your house. Don't repeat an ultrasound, and keep doing whatever you've done, because you're doing damn good at the age of 80 years. So he looks at his wife and she's so, okay, no more restrictions, and they go happy. That is one thing. But the second end of the spectrum, this 17-year-old boy, I'm going to be harsh on him, because imagine he's got how many years more to go? 15, 20 years. When this liver is going to give him trouble, and that 15, 20 years, as I told you, he'll be still very, very young. So the advice is correct the risk factors. Write a note for your diabetologist that you referred this case. Please make sure that his compliance, the patient's compliance to your therapy is good. Keep the HbA1c within a certain range. Strict control of diabetes. You've got to correct his hyperlipidemia, triglycerides and cholesterol. Got to bring them in the range, because when you have too much of baggage at home, too much of fat in the blood, you've got to keep them in wrong places. And liver is one of them. That is second. Third is most important. There was a study in which I was involved as a part of advising in urban affluent. Read this, not rural, not normal, urban affluent school population, where we found that the prevalence rate of non-alcoholic fatty liver disease in these young boys and girls was more than 50%. So this, you've got to tell them that, listen, we're all very fond of fast food, junk, everything. But the point is, do what you want. He said, "Doc, I can't have a burger." I said, "Eat everything in this world, what you want. But bottom line is, next time you come to me, this weight should have been gone down by this many kgs. How you do it is up to you." So he said, "That means I can't eat all that." I said, "I never said that. But you got to check your weight. Because today, in the type of population we treat, you've got to be a little careful. I'll tell you, a person is coming to you in 15 minutes, and I have got experience. He comes to me, his lifestyle has been changed absolutely 180 degrees. He does 2 visits to the doctor, he stops going. And I've had people take 3 months to get them out of depression, that you're not at the end of the road, you will live, don't worry. Because you've got to please advise. You're not advising a machine. You're not switching off the switch, okay, machine on, machine off. You are handling a human mind, a human body, and a person who's lived a certain life for years. You tell him tomorrow morning onwards, no alcohol, no non-veg, no meatha, no sweets. You can imagine what happens to him. He may lose weight, but he may lose his mind also. So that is the most important thing. So risk factors. Third is this, there are some medicines available. But I always tell my patients one thing, that I know you will not control your diabetes in one day. You will not lose 20 kg in one day. You will not control your cholesterol in one day. Till that time, here is the medicine I give you, only to protect your liver from the adverse effect of fat. It's like if it's raining outside, you're going, please take an umbrella, keep doing your work. And when the targets are achieved of diabetes, your weight and cholesterol, I'll withdraw the medicine. It's not lifelong, 6 months, 1 year, but good, safe, effective medicines are available.
Wonderful. Thank you. That's very encouraging and for all of us. And yes, we do have one more topic for you, Dr. Thakur, and this is so very common these days. Everybody wants to, go for gluten-free diet, and but there are some people who actually suffer from gluten intolerance or gluten sensitivity with belching, bloating, abdominal tenderness, even pain and loss of weight and low energy levels. So, what would you recommend for such a thing? Any tests for this condition, and how do we go about it?
The gluten-free has now become, it is scientifically very correct, but somewhere, I find these days it has become a fashion in our affluent society also, because most of the people, many people who come to me with chronic gastric problems, I'm not blaming, I'm saying maybe because they get helpless, because people like us are not able to relieve their symptoms that they want to improve. So they go and leave gluten. So gluten intolerance, which is also called celiac disease, again, the answer to your question will be, I am going to look at the age of my patient who is being treated. If I'm going to be, I often am confronted with a child 5 years, 6 years, and the mother brings, mera bachcha khata nahi hai, mere bachche ka pet ki takleef hai. He is not growth and development, he is growth and development affected. You must think of gluten allergy. Please remember, if you're going to stop gluten in him or her, this child, it's a lifelong decision. No physician has the right to say, अपने बच्चे का gluten बंद कर दो, unless he has done adequate effort, as he would do on himself to prove that it was gluten allergy. And for this, certain tests are available. They are called there's a gluten. In fact, in most of the labs, they have a gluten allergy panel, blood test, plus we do a endoscopy and take a biopsy from the small intestine to prove that, see, the blood is saying gluten allergy, the small intestine is suffering from injury, leave wheat. It's a lifelong decision. In adults, where we also get patients, you'll be surprised. The other day, I had one of the very senior doctors in practice, over the age of 80. Constant symptoms, suffering. Maybe out of frustration, I thought that, being a doctor, if I make this suggestion to that colleague, they may even just brush me aside. I said, okay, we both are fed up of not being able to help you, just leave me. Okay, should I do some tests? Please remember, tests have no value in adults. So don't waste your time. The proof of the pudding is in eating it. 1 month, leave gluten, go on a gluten-free diet. We've got experts, like I think one of the experts in this panel only. Please, they'll start asking me, okay, tell me all the options. I said, hold on. There's a person who knows better than me on gluten. Please go to him or her. They get a chart. You'll be surprised. 30 days later, the patient says, I have stopped my antacids, I have stopped my prokinetic, my motions are better. Doc, I didn't believe you when you said that, but I think it was gluten allergy because I have recovered. So gluten allergy is a very common problem. And practicing in North India, I have followed this system that before I tell my patient gluten band kar do, I must work hard enough to have ruled out everything. Because the moment I tell someone gluten band kar do, he reaches home and his mother or wife calls me. He said, Doc, what am I going to do? ये क्या आपने advice दे दी है? ये तो बचपन से खाता है, ये करता है वो करता. So you got to be prepared to answer questions to those people who are the house managers who are now going to give him 3 meals a day, and he is going to say gluten mat dena. So it is a very, very common problem, and you got to approach it depending on the type of patient that is in front of you.
It has been such a wonderful session, Dr. Thakur. In fact, we will like to have you again because there's so many questions coming up. Maybe in future we'll like to have another session with you. And thank you so much for sharing your experience and invaluable advice. And our attendees and we too actually have benefited so much with better understanding of what, why, and how of common gastrointestinal problems. And I'm sure this is going to remove many, many misconceptions and anxieties amongst all. So thank you once again, and thank you so much.